Welcome back. Let's dive right into part 2 of our explainer on medical billing modifiers. Today, we're demystifying 3 of the absolute most crucial, yet honestly, most misunderstood modifiers in the game. We're talking 25, 26, and TC. But hey, before we unpack this masterclass, make sure to like, share, and subscribe to Decode Healthcare with Harshal.
So here's the high-stakes reality. Incorrectly using the modifiers we're covering today, well, it doesn't just lead to a simple claim denial or a frustrating payment delay. It can trigger massive compliance violations, potential fraud allegations, and just devastating revenue loss. You have to ask yourself, are your claims flying under the radar right now, or are they waving a massive red flag for OIG and RAC auditors? Let's fix that.
First up, Modifier 25. This one is defined as a significant, separately identifiable E&M service by the same physician on the same day as a procedure. Basically, Modifier 25 has one core mission. It's your way of proving to a payer that you performed a significant, totally separate evaluation and management service on the exact same day as a minor procedure. Its whole purpose is to establish that this E&M service was distinctly different from the standard procedure.
So, when do we actually use it and when do we absolutely avoid it? The rule of thumb here is you append 25 when the EM service goes completely above and beyond the usual pre- and post-operative care for a procedure. You absolutely do not use it when the EM is just minor routine care for that procedure. Oh, and if the EM service led to the decision for surgery, don't use 25. For that, you'd actually use Modifier 57.
Now, to survive a RAC audit, you need armor, right? And in coding, your armor is your documentation. For Modifier 25, the requirements are rigid. You need a completely separate, distinct note for the EM service in the patient's medical record. There has to be a clear indication that you addressed a totally different diagnosis, or you have to definitively prove the service was significant beyond just routine care. And yeah, it goes without saying, but the documentation actually has to meet all the requirements for the specific EM level you're billing.
Let's look at how this plays out in the real world with 2 scenarios directly from our source guide. Scenario 1, imagine a patient comes in for a scheduled wart removal, but while they're sitting there, they complain of chest pain. You go ahead and perform a detailed history and exam for that chest pain. That is a completely separate issue, so you're going to bill the EM with Modifier 25 right alongside that wart removal. Scenario 2, say an established patient is in for a simple suture removal but mentions some new diabetes symptoms. You manage the diabetes, boom, same thing. Bill that EM with Modifier 25.
I really need you to hear this loud and clear. Modifier 25 is incredibly high risk. It is heavily scrutinized by payers, and RAC audits frequently target it. Why? Simply because it's used so often, and there's a huge potential for inappropriately unbundling E&M services from procedures. So remember, your documentation must perfectly support that separately identifiable service, or you are definitely going to lose that revenue.
Okay, now that we've secured your EMM claims, let's go ahead and pivot away from those office visits and dive right into the world of radiology and cardiology. Yep, it is time to talk about the split billing concept.
Welcome to the split billing duo. We've got Modifier 26, the professional component, and Modifier TC, the technical component. It's actually pretty simple. When a single procedure has 2 distinct halves, we literally split them. Modifier 26 is the physician's interpretation and written report. Modifier TC, on the other hand, covers the facility's physical equipment, the supplies, and the technical staff that actually run the test.
So when do you use 26 versus TC? You use Modifier 26 when a provider interprets a test, like an X-ray or an EKG, but they don't actually own the machine it was performed on. Conversely, Modifier TC is billed by the hospital or the outpatient facility, because they're the ones who actually own the resources and pay the technicians running the equipment.
But here's where coders trip up. When should you not use 26 or TC? Do not use either of these modifiers if you are billing for the complete global procedure. That means the physician owns the equipment and provides both the technical test and the professional interpretation. You also can't use these on procedures that just don't have separate professional and technical components built into their code description.
Let's map this out with some real-life radiology and cardiology examples. Imagine a hospital performs a chest X-ray using their own equipment. The hospital bills the TC modifier, but an outside radiologist interprets that exact same film and writes up the report. Well, that radiologist bills the CPT code with Modifier 26. Same exact logic goes for an outpatient imaging center doing an MRI. The center bills TC, the interpreting radiologist bills 26, 2 halves making a whole.
Now, while they aren't quite as risky as Modifier 25, 26, and TC still carry a solid medium compliance risk, you have to ensure split billing arrangements never exceed the global payment. Auditors are always watching to make sure the combined amounts don't go over that global cap. Plus, missing the written interpretation report for Modifier 26 or accidentally duplicating claims where both sides try to bill globally, total red flags.
Let's wrap this all up with a quick table comparing what we've covered today. Modifier 25 isolates EM services and, as we know, carries a high audit risk. Modifier 26 covers the physician's professional interpretation, while TC covers the facility's technical resources. Both of those sit right at a medium risk level. Locking in these rules is going to immediately protect your practice's revenue cycle.
Coming up in Part 3, we're diving into surgical and procedural modifiers. We'll be looking at 50, 51, 52, 53, and 57. That brings this breakdown to a close. Thank you so much for joining me for Part 2 of this explainer. Don't forget to hit subscribe so you don't miss that highly requested Part 3. But before you go, I want you to really think about this. If an auditor pulled your last 10 split-billed claims today, right this second, would they actually survive the scrutiny? Think about it. Keep that documentation bulletproof, and I'll catch you in Part 3.